And welcome back to another stream of Advanced Pathophysiology. Today we're looking at Chapter 40, the alterations of renal and urinary tract function in children. As always, our chapter pages may not be the same. However, we will read through pretty much the entirety of the chapter. Uh, it says on my end to stop before urinary incontinence, but it's like 2 pages, so I'll cover it. So we'll do the entirety of the chapter. So jumping right in, renal and urinary disorders occur in children as well as adults. In childhood, however, the kidney and genitourinary structures are continuing to develop, so renal dysfunction may be associated with mechanisms and manifestations that are different from those in adults. In addition, some renal and urinary disorders are congenital and involve structural anomalies of the kidneys and urinary drainage system. So, structure and function of the urinary system in children, the development of the urinary system. The embryonic urinary system, pushing buttons, apologies. Uh, the embryonic urinary system develops as 3 sets of sequentially replaced organs: the pronephrons, the mesonephrons, and the metanephrons. The pronephron, or nephros, is a non-functional structure that arises at the level of the cervical and upper thoracic region during the third fetal week, and connects the primitively Wolvian duct to the cloaca as the foundation for male sexual development. The development of the mesonephros and metanephros is described in Figure 40-1. The Wilms tumor 1, WT1, gene plays an important role at all stages of kidney development and maintenance of kidney function. So if this is our Figure 1, So the embryonic development of the kidneys, the mesonephros, begins development more caudally about the fourth fetal week and begins excretory function in the sixth. Most of the mesonephros degenerates and disappears by the end of the embryonic period. The metanephros, the permanent kidney, arises distal to the bifurcation of the aorta and develops from 2 different sources. The ureteric bud, the metanephric duct, forms as an outgrowth of the mesonephric Wolvian duct and grows dorsocranially and starts subdividing to become the collecting system for the kidneys by forming the ureter, renal pelvis, and calyces. By the 5th fetal month, it will have progressively branched into the collecting ducts, and the metanephrogenic mesenchyme sits atop the terminal branches of the collecting ducts and develops into primitive glomeruli and uriniferous tubules. So in picture A, genetic information from the metanephrogenic mesenchyme guides the development of the ureteric bud, establishing the connection between the uriniferous tubules and the collecting ducts. It is a vital part of kidney development. Errors in this stage can result in polycystic kidneys. As the embryo grows and the definitive kidneys migrate from the caudal position to the lumbar region and the ureters connect with the bladder, in the 8-week male embryo, the Wolvian ducts begin to give rise to the epididymis, the seminal vesicles, and the caudal part of the vas deferens. The external genitalia develops between 8 and 16 weeks, and the testicular descent begins in month 7 of gestation. So, after glomeruli and the tubules form, the tissues organize and progressively differentiate over approximately 30 days. Initial glomerular development is staggered, so there are glomeruli in the various stages. In fact, a few of the first glomeruli that are formed degenerate and disappear during the later stages of fetal development. Progressive development continues into the ninth fetal month, when all metanephrogenic tissue then disappears. As the embryo develops and the vertebral column straightens, the kidneys appear to ascend to the sacral area at about 6 weeks, to the third lumbar area by the third month, and to the first lumbar area at term. The kidneys rotate 90 degrees as they ascend so that renal tissue is lateral and the collecting system is medial. While the kidneys mature, the cloaca becomes the urogenital sinus. It then differentiates into the vesico-urethral canal, which forms the bladder, and the upper urethra, and the urogenital sinus, which forms the main branch of the urethra. At birth, the kidneys occupy a large portion of the posterior abdominal wall, and the ureters are proportionately shorter than those of an adult. All the nephrons are present at birth, and their number does not increase as the kidney grows and matures. The kidney reaches adult size by adolescence and, because of maturation of the tubular systems, increases in weight fivefold from the time of birth. Urine formation and excretion begin by the third month of gestation, contributing to the amniotic fluid. In infancy, the bladder lies close to the abdominal wall, making urinary bladder aspiration for diagnostic purposes a relatively simple procedure. The bladder descends into the pelvis with growth, changing from a cylindrical organ to the adult pyramidal shape. Although small amounts of urine are found in the bladder at birth, the newborn may not void for 12 to 24 hours. Immediately at birth, the renal blood flow and the glomerular filtration rate increase because of a decrease in vascular resistance and the need to perform excretory function no longer performed by the placenta. Renal vascular resistance remains high in newborns and infants, however, which may be attributed to the increased levels of circulation and circulating renin. The resistance progressively declines during the first year of development. With an increasing fraction of the cardiac output going to the kidneys, the GFR continues to increase, achieving adult levels by 2 years of age. Fluid and electrolyte balance in children. Because the kidney develops from the center toward the periphery, renal distribution of blood flow during the newborn period is primarily to the renal medulla. The result is a preferential flow to the medullary nephrons, which have comparatively short loops at this stage of development. The combination of higher blood flow and shorter loops produce a more dilute urine, up to 6 months of age, approximately 400 to 600 MOSM, compared to 800 to 1200 MOSM in adults. The immature kidney is also less responsive to the actions of antidiuretic hormone than vasopressin. The dilute urine is accentuated by a low rate of urea excretion, which is necessary to establish the concentration gradient in the medulla. Urea excretion is low primarily because infants are in a high anabolic state and use of their protein for growth. Because of a high hydrogen ion concentration, limited ability to regulate the internal environment, and lowered osmotic pressure, the infant's renal system has a narrow chemical safety margin. The immature and smaller surface area of the tubules also may diminish the water reabsorption response to antidiuretic hormone. An immature tubular transport capacity means that the ability to excrete a potassium load reabsorbed bicarbonate or buffer hydrogen with ammonia does not become efficient until approximately 2 years of age. Consequently, any disturbance such as diarrhea, infection, fasting for diagnostic tests, or improper feeding can rapidly lead to severe acidosis and fluid imbalance because the infant can rapidly develop over or underhydration or have edema. At birth, infants have a natriuretic response to atrial natriuretic peptide and a normal contraction in extracellular fluid, that ECF, volume, with an accompanying loss of body weight. After birth, the proportion of total body water to body weight does not change markedly. Considerable change does, however, occur in the location of that body water as the child matures. Compared to an adult, the percentage of extracellular fluid volume of the newborn infant is nearly double. Decrease in extracellular fluid volume occurs in two different periods of rapid growth: infancy and adolescence. An infant has not only a greater content of extracellular fluid, but also a greater rate of fluid exchange. The adult consumes and excretes approximately 2 liters of water daily, representing 5% of the total body fluid or 14% of the extracellular fluid. In contrast, the infant's daily exchange of 6 to 700 ml represents 290% of the total, or nearly 50% of the extracellular volume, making control of dehydration and overhydration more difficult. The composition of body fluids differs slightly with age. The total electrolyte concentration in extracellular fluid is greater in the newborn than in the adult. The concentrations of sodium, chloride, phosphate, and organic acids are also greater. The concentration of bicarbonate ions is lower in the infant than in the older child, with a mild acidosis evidenced by a lowered pH. The variations, combined with lowered plasma protein level, cause a reduced oncotic pressure of the vascular compartment and favor accumulation of fluid in the tissue space, and an increased GFR. In the healthy child, these differences remain for a few weeks or months. The premature infant and the normal newborn infant are usually in a state of well-compensated acidosis and potential edema. Alterations in renal and bladder function in children. Congenital abnormalities. Congenital abnormalities of the kidney and urinary tract occur in about 1% of newborns. Structural abnormalities range from minor non-pathologic or easily correctable anomalies to those that are incompatible with life. For example, the kidneys may fail to ascend from the pelvis to the abdomen, causing ectopic kidneys, which usually function normally. The kidneys also may fuse in the midline as they ascend, causing a single U-shaped horseshoe kidney, with an incident rate of about 1 in 600 births. Approximately 1/3 of individuals with horseshoe kidneys are asymptomatic. The most common associated problems are hydronephrosis, infection, stone formation, and tumors. Collectively, structural anomalies of the renal system account for approximately 45% of cases of renal failure in children in developed countries. Many are linked to gene defects. Some anomalies are obvious at birth, whereas others will remain silent or become apparent in childhood. The following structural anomalies can be associated with urinary tract malformations: low-set malformed ears, sensorineural deafness, chromosomal disorders, especially trisomy 13 and trisomy 18, absent abdominal muscles, the prune belly syndrome, vertebral and extremity anomalies, imperforate anus, renal and extrarenal tumors, so nephroblastomas, ocular abnormalities, coloboma of the iris, congenital cataracts, and hepatic cysts or cirrhosis. Your hypospadias, hypospadias is a congenital condition in which the urethral meatus is located in the ventral side or the undersurface of the penis. The meatus can be located anywhere on the glands: proximal hypospadias, the penile shaft, and the base of the penis, the penoscrotal junction, or the perineum, a distal hypospadias. Partial absence of of the foreskin, inguinal hernia, or cryptorchidism. undescended testes, are associated with the anomaly. This is the most common anomaly of the penis. The incidence varies geographically, ranging from 1.86 to 5 per 10,000 infant boys. The etiology is multifactorial and related to disruption in male hormones, including testosterone biosynthesis defects, steroid 5-alpha reductase type 2 mutations, genes associated with penile and urethral development, hormone administration for in vitro fertilization, advanced maternal age, and other environmental factors. Your chordate, or the penile torsion, may accompany hypospadias. In chordate, a shortage of foreskin or shortage of skin on the ventral surface causes the penis to bend or to bow ventrally. Penile torsion is a rotation, usually in the counterclockwise direction of the penile shaft. So here we see the hypospadiasis. Or the chordae urethral meatus. A perineal hypospadiasis with chordae and parietal penoscrotal transposition. The goals for corrective surgery on the child with a hypospadiasis are a straight penis when erect to facilitate sexual intercourse as an adult, a uniform urethra of adequate caliper to prevent spraying during urination, a cosmetic appearance satisfactory to the individual, and repair completed in as few procedures as possible. Improvements in microsurgical techniques have enhanced outcomes and decreased complications and the need for follow-up surgery. Surgery is usually performed between 6 and 12 months of age. Your epispadias and extrophy of the bladder are the same congenital defects but expressed to a different degree. The dorsal urethra is not fused in epispadias and has failed to form into a tube. In boys, the urethral opening may be small and situated behind the glans, or a fissure may extend the entire length of the penis and into the bladder neck. In females, a cleft along the ventral urethra usually extends to the bladder neck. The incidence of epispadias is about 9.25 per 100,000 in hospital live births. It is seen predominantly in males. Continence is determined in part by the location of the defect, with urinary incontinence rates of up to 75% in children with distal epispadias. Treatment, again, is a surgical reconstruction. Extrophy of the bladder. Extrophy of the bladder is a rare, extensive congenital anomaly of herniation of the bladder through the abdominal wall, with failure of the abdominal muscles, pelvic ring, and pelvic floor musculature to fuse in the midline. The posterior portion of the bladder mucosa is exposed and appears bright red. The prevalence of extrophy of the bladder is about 1.7 in 100,000 live births. The extrophy of the bladder is caused by intrauterine failure of the abdominal wall and the mesoderm of the anterior bladder to fuse. The clitoris in girls is divided into two halves with the urethra between them. The penis is in boys an epispadias. Urine seeps onto the abdominal wall from the ureters, causing a constant odor of urine and excoriation of the surrounding skin. Because the exposed bladder mucosa becomes hyperemic and edematous, it bleeds easily and is painful. It should be covered with silastic or a plastic dressing, like a kitchen plastic wrap, for protection from irritation while permitting urine drainage. The unrepaired extrophic bladder is cosmetically unacceptable and prone to cancerous changes as soon as 1 year after birth. The rectus muscles below the umbilicus are separated, and the pubic rami, the bony projections of the pubic bone, are not joined. In addition, the posterior aspect of the pelvis is externally rotated, which retroverts the acetabula and causes external rotation of the feet. This causes a waddling gait when the child first learns to walk. Most children learn to compensate, but surgical intervention may be required. Ideally, the bladder and the pubic defect should be closed before the infant is 72 hours old. Surgical reconstruction is usually performed within the first year, either as a complete primary repair or as a staged procedure. Staged procedures may include bladder augmentation and bladder neck and epispadias repair. Objectives of management include preservation of renal function, attainment of urinary control, prevention of infection, and improvement of sexual function and quality of life. The cloacal exstrophy is the most rare and severe form of bladder exstrophy. The intestines, genitourinary tract, and spine may be involved, and reconstruction with restored urine and fecal control is difficult. Ureteropelvic junction obstruction is a blockage of tapered point where the renal pelvis transitions into the ureter, also known as UPJ. Most cases are caused by intrinsic factors, such as a stricture or an aperistaltic ureteral segment, whereas extrinsic factors, such as crossing vessels, are rarely seen. It is the most common cause of hydronephrosis in neonates. Diagnosis is made by ultrasound. Open or endoscopic surgery to relieve the obstruction occurs if there is decline of renal drainage or function. Your secondary ureteropelvic junction obstruction is caused by kinking or extrinsic compression by an aberrant lower pull vessel. Children with UPJ obstruction have an increased risk of vesicoureteral reflux. UPJ obstruction can be associated with ureteral duplication, including complete ureteral duplication, abnormal growth of two ureters, and ureteral orifice, draining a single kidney, and incomplete duplication. The bifurcation of ureter terminates into one ureteral orifice and serves a single kidney. Obstruction of the distant ureter causes dilation of the entire ureter, renal pelvis, and calyxal system. Megaureter can occur when a short acontractile segment of the ureter develops just above the ureteral vesicle junction or from ureteral reflux. Your ureterocele, or cystic dilation of the intravesical ureter, impedes drainage from the associated kidney. We can also have bladder outlet obstruction. Congenital causes of bladder outlet obstruction are rare and include urethral valves, urethral polyps, and urethral atresia. A urethral valve is a thin membrane that occludes the urethral lumen and obstructs urinary outflow in males. It is the most common cause of congenital lower urinary tract obstruction and renal failure. Most valves occur in the posterior urethra, PUV, although a few arise from the embryologically distinct anterior urethra. Urethral polyps arising from the prostatic urethra are rare. Symptoms of polyps may include hematuria, voiding issues, such as urinary retention or straining to void, and dilation of the upper tract. Urethral atresia is absence of the urethra and is rare. Congenital urethral valves or polyps can be diagnosed with prenatal ultrasound and treated with prenatal bladder shunting or with resection during the first days of life. Severe obstruction may impair renal embryogenesis and lead to renal failure. Your hypoplastic or dysplastic kidneys. During embryologic development, the ureteric duct grows into the metanephric tissue. triggering the formation of the kidneys. If this growth does not occur, the kidney is absent, a condition called renal aplasia. A hypoplastic kidney is small with a decreased number of nephrons. These conditions may be unilateral or bilateral. The occurrence may be incidental or familial. Bilateral hypoplastic kidneys are a common cause of chronic renal failure in children. Segmental hypoplasia, the ask-upmark kidney, may be congenital or secondary to vesicoureteral reflux. Systemic hypertension is a common presentation. Renal dysplasia usually results from abnormal differentiation of the renal tissues. For example, primitive glomeruli and tubules, cysts in non-renal tissue, such as cartilage, are found in the dysplastic kidney. Dysplasia may be the secondary to antenatal obstruction of the urinary tract from uteroceles, posterior urethral valves, or prune belly syndrome. Renal agenesis. Renal agenesis, the absence of one or both kidneys, may be unilateral or bilateral and may occur randomly or be hereditary. It may be an isolated entity or associated with anomalies in other organs. Unilateral renal agenesis occurs in approximately 1 in 1,000 live births in the United States. Males are more often affected, and it is usually the left kidney that is absent. The single kidney is often completely normal, so that the child can expect a normal, healthy life. The normal solitary kidney grows because of compensatory hypertrophy before and after birth. By the time the child is several years old, the volume of this kidney may approach twice the normal size. In some instances, the single kidney is abnormally formed and associated with abnormalities of the collecting system. Because the child has a decreased number of nephrons, there is a risk for hyperfiltration injury, increasing the chance of developing proteinuria, hypertension, and chronic kidney disease. Extrarenal congenital abnormalities of the urogenital, skeletal, cardiac, or other systems may coexist. Bilateral renal agenesis, also called Potter syndrome, is a rare disorder incompatible with extrauterine life. Approximately 75% of the affected infants are male. Bilateral renal agenesis results from either an abnormal development of the normal progression from pronephros to mesonephros to metanephros, or an isolated bilateral failure of development of the ureteral buds. The term Potter syndrome refers to the association with a specific group of facial anomalies: wide-set eyes, parrot beak, nose, low-set ears, and receding chin. Oligohydramnios. Low amount of amniotic fluid leads to underdeveloped lungs. Affected infants rarely live more than 24 hours because of pulmonary insufficiency. Approximately 40% of the affected infants are stillborn. Renal agenesis can be detected prenatally via ultrasound. Very sad. Polycystic kidneys. The autosomal dominant polycystic kidney disease, ADPKD, is an inherited disorder that occurs in about 1 in 1,000 live births in the US. Mutation of two genes, PKD1, chromosome 16, and PKD2, chromosome 4, account for the disease, most often presenting in late childhood or adulthood. The gene products, polycystins, regulate growth and differentiation of the tubular epithelium. Defects in the formation of epithelial cells and their cilium result in cyst formation and obstruction, accompanied by destruction of renal parenchyma, interstitial fibrosis, and loss of functional nephrons. Cysts may occur in other organs, including the liver, seminal vesicles, and pancreas. Hypertension, heart valve defects, and cerebral and aortic aneurysms may develop. Urinary tract infections, hematuria, and flank pain may occur. Diagnosis is usually confirmed by ultrasound. Individuals may live for decades before developing symptoms of renal disease, and not all progress to end-stage disease. Tolvaptan, a competitive vasopressin receptor 2 antagonist, may slow progression of the condition. Autosomal recessive PKD with cystic changes in the kidney and liver is often first suspected on a prenatal ultrasound. Gene mutation in PKHD1 result in reduced or absent function of fibrocystin, which is required for tubulogenesis. Renal replacement therapy is usually required during childhood or adolescence. Glomerular disorders. The most common glomerular disorder in children are glomerulonephritis, nephrotic syndrome, and hemolytic uremic syndrome. Most glomerular diseases are acquired and immunologically mediated. The disease can be acute or chronic. The likelihood of developing renal failure depends on the specific condition. The most common glomerular disorders in children are presented next. Glomerulonephritis. Acute glomerulonephritis includes a number of renal disorders in which inflammation of the glomeruli are secondary to an immune mechanism. The symptoms usually include the sudden onset of hematuria with red blood cell casts and proteinuria, and can be accompanied by renal salt and water retention, edema, hypertension, and in severe cases, azotemia. Glomerulonephritis is the causative factor for 15 to 29% of end-stage renal disease in children. So acute post-streptococcal glomerulonephritis, or PSGN, is one of the most common immune complex-mediated renal diseases in children between 5 and 15, and it is representative of acute glomerulonephritis. It most commonly occurs after a throat, pharyngitis, or skin impetigo infection with nephritogenic strains of group A beta hemolytic streptococci, although other bacteria, such as the staphylococcus and viruses, also may be responsible. Occurrences have been observed after bacterial endocarditis, which may be associated with streptococcal or staphylococcal microorganisms, or after viral disease, such as varicella and hepatitis B and C. Glomerulonephritis develops with a deposition of antigen-antibody complexes, immunoglobulin G or IgG, and C3 complement in the glomerulus, or the antigen may be trapped within the glomerulus and immune complexes form in situ. The exact mechanism of immune complex formation is unknown. The immune complex initiate inflammation and glomerular injury. Immunofluorescent microscopy shows lumpy deposits of IgG and C3 on the glomerular basement membrane. The thickened glomerular membrane contributes to decreased GFR. Activated complement inflammatory cytokines, oxidants, proteases, and growth factors attack the epithelial cells, alter membrane permeability, and cause hematuria and proteinuria. Hypertension occurs primarily because of the fluid retention. So we're looking at some slides here. Symptoms usually begin 1 to 2 weeks after an upper respiratory tract infection, more common during the cold weather, and up to 6 weeks after skin infections such as impetigo. The onset of symptoms in the child is abrupt, varying with disease severity. The urine is usually smoky brown or cola-colored because of the presence of red blood cells. The child may complain of flank or mid-abdominal pain, irritability, general malaise, and fever. Acute hypertension may cause headache, vomiting, somnolence, and other central nervous systems manifestations, including seizures. Cardiovascular symptoms are related to circulatory overload and are compounded by hypertension. These include dyspnea, tachypnea, and an enlarged tender liver. The most severely affected children develop acute renal failure with oliguria. The disease usually mild and run its course in 1 month, but urine abnormalities may be found up to 1 year after the onset. As many as half the children affected are asymptomatic. Fewer than 5% of children become oliguric or develop rapidly progressive glomerulonephritis or progress to chronic glomerulonephritis. Prolonged proteinuria and abnormal GFR indicate an unfavorable prognosis. More than 95% recover completely. Fewer than 1% of the children develop end-stage renal disease. So your immunoglobulin A nephropathy, or IgA nephropathy, is the most common form of glomerulonephritis in children and young adults worldwide, and occurs more often in males. The cause is unknown. It is characterized by deposition primarily of IgA and complement proteins in the mesangium and the glomerulus. Abnormal glycosylated IgA1 is produced by the bone marrow. Glycan-specific IgA antibodies are formed against abnormal IgA1, can activate complement and bind to glomerular mesangial cells, stimulating them to proliferate, secrete extracellular matrix proteins, and release inflammatory cytokines and chemokines that interleukin-6, tumor necrosis factor alpha, and transforming growth factor beta 1, which causes the injury. The immune response contributes to diffuse mesoangioproliferative glomerular injury and glomerulosclerosis, which is usually reversible. Children with this disease have recurrent gross hematuria concurrent with respiratory tract infections, tonsillitis, or gastroenteritis. Most continue to have microscopic hematuria between the attacks of gross hematuria and have mild proteinuria. Treatment is supportive. Proteinuria, edema, and hypertension are more severe symptoms and must be treated to prevent future loss of kidney function. Some children recover completely, whereas 20 to 40% eventually will require dialysis and transplantation. IgA nephropathy may recur following transplantation. That leads us to the Henoch-Schönlein purpuranephritis, also known as anaphylactoid purpura, which is an immune-mediated IgA vasculitis that affects glomerular blood vessels, causing inflammation and damage to the vessel wall. The disease also involves small vessels in the skin and gut. Classic symptoms of HSP include palpable purpura, arthritis, and abdominal pain. About 21% of children develop renal disease characterized by gross or microscopic hematuria with mild or no proteinuria, usually within 4 weeks of disease onset. Kidney biopsy demonstrates IgA deposition into the mesangium. The development of interstitial fibrosis and crescent formation from subepithelial immune deposits, along with glomerular, increase the risk of chronic renal failure. Most children recover with supportive care, although some progress to kidney failure. Severe symptoms require corticosteroids, other immunosuppressant drugs, or angiotensin-converting enzyme inhibitors, or ACE inhibitors. Hemolytic uremic syndrome. Hemolytic uremic syndrome is an acute disorder characterized by microangiopathic hemolytic anemia, thrombocytopenia, and renal impairment. It is the most common community-acquired cause of acute renal failure in young children. The disease occurs most frequently in infants and young children, younger than age 4. The prognosis has improved dramatically in recent years, with more than 90% of children surviving and most regaining normal function. So what is the pathophysiology? HUS has been associated with both bacterial and viral agents, as well as endotoxins, especially from E. coli, and recent Escherichia E. coli, different variations of E. coli. Potential sources of exposure include animals, unpasteurized beverages, and contaminated meat and vegetables. The disease also occurs with cancer and use of chemotherapeutic agents. The HUS virotoxin from E. coli is absorbed from the intestines into the blood, binds to polymorphonuclear leukocytes, and is transported to the kidneys, causing a cascade of effects, including lysis of glomerular capillary endothelial cells, separation of endothelial cells from the basement membrane, activation and aggregation of platelets, and activation of the coagulation cascade. The glomerular arterioles become swollen and occluded with platelets and fibrin clots. There is decreased glomerular filtration, and the damaged glomerular membrane result in hematuria and proteinuria. Oliguria with renal failure occurs in up to 50% of children. Narrowed vessels damaged by passing erythrocytes. These damaged red blood cells, identified as Burr cells, helmet cells, and fragmented red blood cells, are removed by the spleen, causing acute hemolytic anemia. Fibrinolysis, the process of dissolution of a clot, acts on precipitated fibrin, causing the fibrin split products to appear in serum and urine. The platelet clustering within damaged vessels, combined with the damage and removal of platelets, produces thrombocytopenia. Fibrin-rich thrombi can be found throughout the microcirculation. Other tissues, including the brain, liver, heart, and intestines, are often involved. So what kind of manifestations do we see clinically? Typically, HUS is preceded by a prodromal gastrointestinal illness with diarrhea and is known as D plus HUS, diarrhea plus HUS. Atypical HUS is not associated with diarrhea and is known as D minus HUS. Dysregulation of the alternative complement pathway is often noted. Familial HUS is rare and defined as a diagnosis of HUS in at least two members of the same family, at least 6 months apart. The onset of D plus HUS occurs about 1 to 2 weeks after a GI illness with a symptom-free 1 to 5 day period. There is a sudden onset of pallor, bruising or purpura, irritability, and oliguria. Slight fever, anorexia, vomiting, diarrhea, with the stool characteristically watery and blood-stained, hemorrhagic diarrhea, abdominal pain, mild jaundice, and a circulatory overload are accompanying symptoms. Seizures on lethargy indicate a CNS involvement. Renal failure is apparent within 2 days to 2 weeks of onset. The renal failure causes metabolic acidosis, uremia, hyperkalemia, and hypertension. The evaluation and treatment, therefore, the clinical evaluation includes a history of pre-existing illness, presenting symptoms, and urine and blood analysis. Antibiotics are not used in the initial treatment because they increase Shiga toxin release and increase the risk to HUS. Management consists of maintaining nutrition and hydration and controlling hypertension and hyperkalemia and seizures. When renal failure occurs, dialysis is indicated. Blood transfusions with packed red blood cells are needed to maintain reasonable hemoglobin levels. Eculizumab, or a C5 inhibitor, has been demonstrated to be efficacious in the treatment of aHUS. Most children recover, however, some will develop hypertension, proteinuria, or renal insufficiency or failure. Death usually occurs from complications related to CNS, infectious, or myocardial causes. Preventing Shiga toxin producing bacterial infections, such as E. coli, prevents D plus HUS. Nephrotic syndrome. Nephrotic syndrome is a term used to describe a symptom complex characterized by proteinuria, hypoalbuminemia, hyperlipidemia, and edema. The syndrome is more common in children than adults, when no identifiable cause is found. The condition is termed primary idiopathic nephrotic syndrome. If it results from a systemic disease or other causes, your drugs, toxins, diabetes, lupus, nephritis, it's called secondary nephrotic syndrome. Primary nephrotic syndrome is usually described by histopathologic results, a minimal change nephropathy, focal segmental glomerular sclerosis, membranous nephropathy, or a membranoproliferative glomerulonephritis. Secondary nephrotic syndrome has the same patterns of histopathology, but is associated with an underlying cause. Approximately 95% of cases of nephrotic syndrome in children occur in the absence of systemic or pre-existing renal disease. Primary nephrotic syndrome is found predominantly in preschool children, with a peak incidence of onset between 2 to 3 years of age. Onset is rare after 8 years of age. Boys are affected again more than girls. No prevalent racial or geographic distribution is evident. The incidence is approximately 2 to 3 children per 100,000 annually. So what is the pathophysiology? The cause of nephrotic syndrome in children is usually idiopathic and includes MCM 85%, FSGS 10%, and mesangial proliferative nephropathy, that MPN 5%. Secondary nephrotic syndrome may develop during the course of several different renal or systemic diseases. The pathophysiology and common clinical manifestations of nephrotic syndrome in adults was described in Chapter 39 and are similar in children. The most common cause of nephrotic syndrome in children is presented here. So, minimal change nephropathy, MCN, also known as a lipoid nephrosis, is the most common cause of nephrotic syndrome in children ages 2 to 6. A systemic immune mechanism is a likely cause of the disease, but the true etiology is unknown. The mechanism of increased glomerular permeability is unknown, but is related, in part, to release of permeability factors from abnormal circulating T cells that injure the glomerular epithelial cells. The glomeruli appear normal by light microscopy, and immunoglobulin depositions is usually absent. The only change is fusion of epithelial cell podocyte foot processes. Loss of the electrical negative charge and the increased permeability within the glomerular capillary wall lead to albuminuria. Hyperlipidemia leads to lipiduria and primarily results from increased hepatic lipid synthesis and decreased plasma lipid catabolism. Focal segmental glomerulosclerosis, FSGS, is present in approximately 10% of children with nephrotic syndrome and is more common in African American. The frequency of FSGS is increasing in children and adults. The primary injury is effacement, a thinning or deletion of the epithelial podocytes, with a significant increase in pore size leading to the impairment of size selectivity and proteinuria. Progressive disease results in proliferation of endothelial and mesangial cells, with occlusion and sclerosis of glomerular capillaries. The more severe the proteinuria, the more likely it is that end-stage renal disease will occur. FSGS is usually steroid resistant. Edema is the classic symptom of nephrotic syndrome. Factors theorized to contribute to edema formation include hypoalbuminemia, a decreased plasma oncotic pressure, and sodium retention. The movement of fluid from the vascular to the interstitial space can decrease blood volume, increase the activity of aldosterone and antidiuretic hormone, that vasopressin, and decrease atrial natriuretic peptide concentration, all of which promote fluid retention. Hyperlipidemia occurs in inverse proportion to the decrease in plasma protein, particularly albumin. There are high concentrations of triglycerides, the low-density lipoprotein, and very low-density lipoprotein, cholesterol. High-density lipoprotein cholesterol concentration is decreased. Hypoalbuminemia leads to a deficiency in the carrier protein for the transport of fatty acids, and they remain elevated in the serum. There is a hepatic compensation for hypoalbuminemia, which increased synthesis of lipoproteins to maintain plasma oncotic pressure. Hypoalbuminemia also leads to an increased hepatic stimulus for synthesis of LDL and VLDL cholesterol by the liver. Serum lipids may remain elevated from 1 to 3 months after remission of proteinuria. Hypercoagulation with risk for arterial or venous thrombosis results from abnormalities in the coagulation pathways during nephrotic syndrome. Although rare, thrombosis can occur in the brain or lung. Family history and predisposing factors should be evaluated. Anticoagulants may be required. Congenital nephrotic syndrome, the Finnish type, is usually caused by an autosomal recessive mutation of the NPHS1 gene that encodes an immunoglobulin-like protein. Nephrin at the podocyte slit membrane, lack of nephrin causes heavy proteinuria. The disease usually manifests before 3 months of life. Treatment consists of intravenous albumin infusions, nutritional supplements, and bilateral nephrectomy followed by dialysis and a kidney transplant. So what kind of clinical manifestations do you see? The onset of nephrotic syndrome is often insidious, with periorbital edema as the first sign. Periorbital edema is most noticeable in the morning, but subsides during the day as fluid shifts to the abdomen and lower extremities. Parents may notice diminished frothy or foamy urine output. When edema becomes pronounced, ascites, respiratory difficulties from pleural effusion, and labial or scrotal swelling may develop. Edema in the interstitial mucosa may cause diarrhea, anorexia, and poor absorption. Edema often masks the malnutrition caused by the malabsorption and protein loss. Because of protein deficiency, changes in the quality of hair indicate a malnourished state. Pallor with shiny skin and prominent veins may be present. Blood pressure is usually normal. The child has an increased susceptibility to infection, especially pneumonia, peritonitis, cellulitis, and septicemia. Irritability, fatigue, and lethargy are common. Infants born with congenital nephrotic syndrome have large fontanelles and separate cranial structures. So our evaluation and treatment. The diagnosis of nephrotic syndrome is evident from the clinical presentation and findings of proteinuria, hyperlipidemia, and edema. Diagnostic tests include kidney biopsy, may be required to determine whether the cause is an intrinsic renal disease or consequence of systemic disease. The goals of treatment are to reduce the excretion of protein and to maintain protein-free urine. Prevention or treatment of infection, control of edema, establishment of the balanced nutritional state, and restoration of normal metabolic processes also are important in managing the disorder and avoiding adverse aspects of the treatment. Basic management of nephrotic syndrome include administering glucocorticosteroids, your prednisone, adhering to a low-sodium, well-balanced diet, performing good skincare, and, if edema becomes problematic, administering diuretics, Lasix or metolazone. ACE inhibitors inhibit formation of angiotensin II and aldosterone, resulting in decreased blood pressure and decreased renal sodium reabsorption. Nephrotic syndrome is often described by the response to steroid therapy. Steroid-sensitive nephrotic syndrome result in remission with steroid therapy alone. Steroid-resistant nephrotic syndrome is the term for children who fail to respond to prednisone within 8 weeks. They may be treated with non-corticosteroid immunosuppressive agents, your cyclophosphamide, or a combination of corticosteroids and non-corticosteroid immunosuppressives to prolong remission. Intravenous rituximab, a monoclonal antibody, has been shown to induce and prolong remission in some children with steroid-dependent or resistant nephrotic syndrome. Children with minimal changes in the disease tend to have a very favorable prognosis, whereas those with steroid-resistant nephrotic syndrome may develop end-stage kidney disease. That leads us to kidney injury. Kidney injury is rare in children. The pathophysiology and management are similar to those for kidney injury in adults. A modification of the Rifle criteria, the risk, injury, failure, loss, and end-stage kidney disease, that was proposed to standardize the definition of acute kidney injury in adults, has been used in critically ill children. So it's a pediatric criteria. The most common cause of pre-renal acute kidney injury are dehydration, hemorrhage, and sepsis. Glomerulonephritis, hemolytic uremic syndrome, and hypersensitivity reactions to drugs or infectious agents are the most common cause of intrinsic acute kidney injury. Obstructive uropathies, such as a posterior urethral valves and obstruction of the uteropelvic junction, are associated with post-renal acute kidney injury. End-stage renal disease in children is commonly associated with congenital renal structural abnormalities. In older children, the most common cause of glomerulonephropathy, renal replacement modalities available for children with end-stage renal disease include peritoneal and hemodialysis and kidney transplant. The use of growth hormone before and after transplant has contributed to normal growth and development. Nephroblastoma, or Wilms tumor, is an embryonal tumor of the kidneys arising from epigenetic and genetic changes that lead to abnormal proliferation of renal stem cells. The incidence of Wilms tumors remains constant in the US, with approximately 500 children diagnosed each year. Most children are between 1 and 5 years of age when they are diagnosed. The peak incidence occurs between 2 and 3 years of age. Wilms tumor is slightly more common in females and in Black than white children, and is less common in Asian children. Microscopically, Wilms tumor is composed of 3 cellular components: stromal, epithelial, and blastemic. This occurs because blastemic cells, which are primitive and undifferentiated, may have partially developed into epithelial or stromal tissue, with each of the 3 cellular components varying stages of differentiation may be evident within the tumor. So what is the pathogenesis? Wilms tumor has sporadic and inherited origins. The sporadic form occurs in children with no genetic predisposition. Inherited cases, which are relatively rare, 1 to 2% of cases, are transmitted in an autosomal dominant fashion. A two-hit hypothesis for the development of Wilms tumor has been proposed wherein children who inherit a mutation in one allele of a tumor suppression gene require just one more somatic mutation for a tumor to form. This hypothesis may not apply to all Wilms tumors, however, because a number of genetic abnormalities have been identified in Wilms tumors. Wilms tumor suppressor genes, WT1 and WT2, are located on chromosome 11. Chromosomal abnormalities include gains, losses, and rearrangements are often present in Wilms tumors. Gains in chromosomes 1q, 2, 7q, 8, 12, and 13, and losses in chromosomes 1p, 7p, 16q, and 22q are among the most common findings, although multiple other chromosomal abnormalities also have been identified. WTX is a tumor suppressor gene located on the X chromosome. Approximately 10% of children who have Wilms tumor also have deletions or mutations of other genes, and therefore have a number of congenital anomalies. These anomalies include aniridia, or lack of an iris in the eye, hemihypertrophy, an asymmetry of the body, a genitourinary malformation, horseshoe kidneys, hypospadias, ureteral duplications, polycystic kidneys, or uterine abnormalities. Children with congenital anomalies, as well as Wilms tumor, are more likely to have the inherited bilateral form of the disease. So what are your clinical manifestations? Most tumors, 90%, present as an enlarging asymptomatic upper abdominal mass in a healthy, thriving child. Many tumors are discovered by the child's parent, who feels or notices an abdominal swelling, usually while dressing or bathing the child. Other presenting complaints include vague abdominal pain, hematuria, and fever. Hypertension may be present, likely because of excessive renin secretion by the tumor. So what's your evaluation and treatment plan? On the physical exam, the tumor feels firm, non-tender, and smooth, and generally is a solitary mass of varying size, confined to one side of the abdomen. Diagnostic imaging demonstrates a solid intrarenal mass. Diagnosis is based on surgical biopsy. Additional lab and radiologic studies are used to evaluate the presence or absence of metastasis. The most common sites of metastasis are regional lymph nodes and the lungs, and less commonly liver, brain, and bone. Staging systems for Wilm tumors have been developed and serve as guides for treatment. The most widely accepted system in the US was developed by the National Wilms Tumor Study Group. The system is based on surgical findings and the extent of disease at diagnosis. Children are further classified as either high or low risk according to favorable or unfavorable histologic presentation, the anaplasia. So, the stages of tumor. Stage 1, 40 to 45%. The tumor is limited to just the kidneys, and they can be completely resected at that point. Stage 2, the tumor ascending beyond the kidneys or into the vessels of the renal sinus, but appearing to be totally resected. Stage 3, residual non-hematogenous tumor is confined to just the abdomen, positive lymph nodes, and renal hyla. Stage 4 is hematogenous metastasis, so it could be to the lung, liver, bone, brain. And stage 5, very rare, only 5%, bilateral disease either at diagnosis or later, but need to stage each kidney separately. So the primary treatment is usually surgical exploration and resection, followed by treatment based on histology, or chemotherapy followed by surgical resection, which limits tumor spillage during surgery. In bilateral disease, surgical intervention may include a heminephrectomy of the less involved kidney and a nephrectomy of the other. Radiation therapy may be used for children with higher stages of disease and metastasis. Survival at 4 years is greater than 90% for localized disease and more than 85% for advanced disease with favorable histology. Congestive heart failure, renal failure, hypertension, and secondary malignancies occur more frequently in long-term survivors than in the general population. So even though your first 3 stages of Wilms tumor, if you have a favorable histology, you stay above 95% pretty much. At stage 4, 86, and at stage 5, 87. So somehow there's a small increase if you're separating more specifically left and right. However, unfavorable histology, that anaplastic Wilms tumor, is 83% already at stage 1, 81% at stage 2, 72% stage 3, and in stage 4, 38%, where If you're staging at stage 4, you might as well stage it to stage 5 to see if you have a more favorable outcome at that point. That leads us to bladder disorders, your urinary tract infections. UTI is the colonization of a pathogen anywhere along the urinary tract, urethra, bladder, ureter, kidney, and occurs commonly in children during the neonatal period, uncircumcised males, and infants with congenital renal abnormalities are at increased risks. Girls have a greater incidence after 1 year of age, with an increasing incidence at adolescence. Sexually active female adolescents are at increased risk to have a UTI. Similar to adult women, susceptibility is increased when genetically controlled blood group antigens, your P1 and Lewis blood group non-secretors, are present on surface uroepithelial cells and act as receptors for bacterial attachment. UTI in females occurs as a result of perineal bacteria, especially E. coli, ascending the urethra, which lies close to the anus. The pathophysiology of UTIs in children is similar to that of adults. Although nephrolithiasis can be associated with UTI in adults, nephrolithiasis in children is rare, but is increasing in incidence. UTIs in children are often clinically categorized as first or recurrent infection. Individual susceptibility, bacterial virulence, anatomy, and genetics affect the severity of the disease. The recurrence rate is approximately 20 to 30%. Cystitis, or infection of the bladder, results in mucosal inflammation and congestion. This causes detrusor muscle hyperactivity and a resulting decrease in the bladder capacity. It also can lead to transient reflux of urine up the ureters, sending bacteria all the way to the kidney, causing acute or chronic pyelonephritis and renal abscesses or scarring. Symptoms of UTI in children are nonspecific, and differentiating whether an infection is in the bladder or kidneys is difficult based on symptoms alone. Infants usually develop fever, vomit, diarrhea, or jaundice. Some children may present only with fever of undetermined origin, and others may present with urinary tract symptoms of frequency, urgency, enuresis, or incontinence in a previously dry child, abdominal flank or back pain, foul-smelling urine, and sometimes hematuria. Acute pyelonephritis usually causes chills, fever, and flank or abdominal pain, along with enlarged kidneys, caused by the edema. Chronic pyelonephritis may be asymptomatic. Diagnosis of UTIs is by urine culture of a pathogen before antimicrobial treatment. An accompanying urinalysis can show pyuria, nitrates, and hematuria. The presence of casts in the urine can indicate pyelonephritis. Ultrasound, voiding, cystourethropy, or radionuclide cystography, or CT, scan may be necessary to rule out obstruction. Abscesses or reflux, particularly in young children who do not respond to antimicrobial therapy. With treatment, UTI symptoms are usually relieved in 1 to 2 days, and the urine becomes sterile. A 2 to 4 day course of oral antibiotics is effective for an uncomplicated UTI. Longer treatment may be required if the child has recurrent UTIs, has a complicated UTI including congenital abnormalities of the urinary tract, or is immunosuppressed. Imaging of children after the first UTI is controversial. The age of the child and seriousness of the infection should be considered when making imaging decisions. Repeat urine cultures are not needed if a child has responded to treatment. Management of constipation, promotion of adequate fluid intake, and elimination of dysfunctional voiding patterns are the cornerstone of minimizing the risk of recurrence. Prophylactic antibiotics may be helpful for some children. Educating families about signs and symptoms of UTIs allows for early identification and treatment. Surgical correction of vesicoureteral reflux or obstruction may be necessary. That leads us to vesicoureteral reflux. VUR is a retrograde flow of bladder urine into the kidney and/or the ureters. Reflux allows infected urine from the bladder to reach the kidneys. Reflux perpetuates infection by preventing complete emptying of the bladder, as reflux urine drains back into the bladder at the end of each void. In addition, reflux allows the maximal intravesical pressure to be transmitted to the renal calyces and pyramids. The combination of reflux and infection is an important cause of pyelonephritis, especially in children younger than 5. The vesicoureteral reflux occurs more often in girls by a ratio of 10 to 1 and is less common in blacks. Its incidence is unknown because in the absence of urinary tract infections, VUR is often undiagnosed. Siblings of those affected have about a 27 to 51% chance of having reflux. And children with parents who had reflux have an almost 70% chance of reflux. The shortness of the submucosal segment of the ureter during infancy and childhood renders the entire flux mechanism relatively inefficient and delicate. Thus, reflux is seen commonly in association with infections during early childhood, but rarely in older children and adults. Reflux may be unilateral or bilateral, and it can be classified or graded for comparative purposes. So if you have your grades of reflux, you have your normal, then you have your slight, your moderate, and then your gross. Grade 1 reflux into a non-dilated distal ureter. Grade 2 is a reflux into the upper collecting system without dilation. Grade 3, reflux into dilated ureter or blunting of a calyceal fornicis. Grade 4, reflux into a grossly dilated ureter. And then grade 5, massive reflux with ureteral dilation and tortuosity and effacement of the calyceal details. Occurs almost exclusively in male patients. Pathophysiology. Primary reflux results from the congenitally abnormal or ectopic insertion of the ureter into the bladder. Occasionally, the condition is hereditary. Secondary reflux may be transient or persistent. It develops in association with infection, malformations of the ureterovesical junction, increased intravesical pressures, voiding disorders, or surgery on the UV junction. Urinary tract infection associated with VUR may lead to permanent renal scarring, particularly when there is pyelonephritis. The actual cause of renal cell damage and scarring is unknown, but contributing factors include inflammatory cytokines activated by bacterial virulence factors. So what are our clinical manifestations? Children with reflux may be asymptomatic or may experience recurrent UTIs or unexplained fever, poor growth and development, irritability, and feeding problems. The family history may reveal VUR or urinary tract infections. So our treatment plan and evaluation include prompt treatment of UTIs in children with reflux. It is important to minimize the risk of renal scar development. Some infants with reflux already have renal scarring at birth. In addition to the history of recurrent UTIs and other symptoms, imaging may be required for diagnosis and assessment of structural change, scarring, urinary tract function, and risk for future infection and renal damage. Identification and resolution of bowel and/or bladder dysfunction is imperative to decrease the risk of urinary tract infections and improve the rate of VUR resolution. Spontaneous remission of grades 1 through 3 reflux occurs at about 50 to 80% in children. Approximately 20% of grade 4 and grade 5 will resolve. The use of prophylactic antibiotics for these children is controversial. with concerns regarding efficacy and the development of antibiotic resistance. Recurrent infection or high-grade reflux are possible indications for surgical intervention or endoscopic injection of biomaterials into the bladder wall below the ureteral orifice. Surgical repair of reflux has been shown to decrease the incidence of pyelonephritis, but does not decrease the risk of developing or progression of renal damage. The value of screening asymptomatic children, the asymptomatic siblings of children with vesicoureteral reflux, is debatable. One current recommendation is to perform a renal ultrasound and consider a VCUG only in children with scarring or otherwise abnormal appearing kidneys. That leads us to our last section here, urinary incontinence. Urinary incontinence refers to the involuntary passage of urine by a child who is beyond the age when voluntary bladder control should have been acquired. Bladder control is accomplished by most children before the age of 5, although this is largely influenced by cultural beliefs and parental toileting training practices. Nighttime wetting is called enuresis. Functional incontinence is urinary incontinence, in which no structural or neurologic abnormality can be identified. The underlying mechanism may include disorders of both the storage and voiding phases of the bladder cycle. A child may have daytime incontinence or enuresis or both. The incidence of incontinence is difficult to determine because it is not a problem that parents readily share with others, and because definitions vary according to cultural norms and family practices. The incidence of enuresis in children older than 5 years of ranges from 15% to 20%. Boys are more enuretic than girls by the ratio of 2 to 1. Fewer than 2% of adults experience enuresis. Daytime incontinence occurs in up to 9% of early school-aged children. So what is the pathophysiology? Multiple factors are likely responsible for incontinence. All or part of each one might be operating in a given child. A reasonable approach is to eliminate organic, behavioral, or physiologic causes before exploring the psychologic ones. Organic causes of incontinence account for 2 to 10% cases. The causes include urinary tract infection, neurologic disturbances, congenital defects of the meatus, urethra, or bladder neck, allergies, constipation, obesity, or alteration in renal tubular ion and water transport related to prostaglandin secretion. Disorders that increase the normal output of the urine, such as diabetes and diabetes insipidus, or disorders that impair the concentrating ability of the kidneys, must be considered in the evaluation of enuresis. Enuresis in children may be associated with maturation lag. Studies have demonstrated that some children with enuresis have smaller functional bladder capacities than non-enuretic children. Children who do not have the normal nocturnal elevation of vasopressin produce a higher volume of urine with a lower osmolality than controls. A number of children experience bladder overactivity with elevated intravesical pressure and spike-like detrusor contractions during bladder filling. Incontinence, often spontaneous, disappears in children as they get older. Genetic factors contribute to some types of incontinence. Multiple gene loci associated with enuresis have been identified. Bedwetting occurs with high frequency among parents, siblings, and other near relatives of symptomatic children. These observations are further supported by a high concordance rate in enuretic monozygotic twins. Multiple studies have examined the role of sleep architecture in enuresis. Findings have ranged from elevated arousal threshold to increased light sleep, with frequent cortical arousal without complete awakening. Enuresis may be associated with obstructive sleep apnea. Inspiratory effort against the closed airway increases intrathoracic negative pressure causing cardiac distension and release of atrial natriuretic hormone and decreased level of vasopressin and renin-angiotensin-aldosterone complex. A variety of psychosocial factors also have been postulated as explanations of enuresis. Enuresis has been associated with attention deficit hyperactivity disorder, anxiety disorder, depression, and oppositional defiant disorder. So, your primary incontinence refers to a condition in which the child has never been continent, whereas your secondary incontinence occurs when a child who has experienced periods of dryness of at least 6 months after toilet training becomes incontinent again. Secondary enuresis may be diurnal, nocturnal, or a combination of both. And the types of incontinence are defined here on this table. So what's our evaluation of incontinence includes use of questionnaires, drinking and voiding charts, physical examination, and a urinalysis. Underlying pathology, including kidney disease, vesicoureteral reflux, urinary tract infection, or neurogenic bladder, is excluded. Radiologic and urodynamic evaluation may be required. Therapeutic management of day and night urinary incontinence begins with education. If the child and family understand the probable etiology of the child's condition, they are better able to choose and participate in therapies that are most likely to succeed. Treatment of daytime incontinence includes behavioral therapy, including timed voiding, fluid management, treatment of constipation, urinary tract infection, and other coexisting conditions, if present, and medication. Your anticholinergic alpha blockers. Enuresis treatment may also include enuresis alarms and other medications. Desmopressin acetate tablets, for instance. And that concludes chapter 40. This was relatively straightforward. Nice little review. I thank you all for watching as always, and we will jump into chapter 41, the structure and function of the digestive system, next. So we'll see you then.